devices and accessories. Essentially what these are is just different tubes and catheters. You know, it'd be great if a majority of our patients were outpatients and they were walkie-talkies, but that's not the case. Most of the patients that come into our department, they're very sick, so they'll have different lines and catheters coming out of them. You need to be aware and conscious when they do come down with these different lines, because you may accidentally pull these lines out. And it does happen. And if it's, you know, just like, let's just say an IV line, okay, usually not a big deal, but if it is some type of line or catheter that is life-supporting, now we have issues. So you need to be conscious of what the patient that is coming down with in assessing them before you do the procedure. So again, you don't accidentally pull something or dislodge any of these lines out. So let's go ahead and start talking about that. First, let's talk about oxygen therapy. Okay, patients will come down with a nasal cannula hooked up to an oxygen tank, and as we know, oxygen is probably going to be the main source of a substance that keeps us alive, right? That's why we breathe. That's why we have a heartbeat. We need oxygen to nourish our vital tissues and organs. So it's very essential to life. So the supply must be constant and it must not be interrupted. As we had discussed before, respiration is a cycle. It's a combination of inspiration, bringing in oxygen, and expiration, getting rid of any waste gas. So what is responsible for the exchange of gases is hemoglobin. Hemoglobin is part of the blood cells that carries oxygen to the vital tissues and organs and carries carbon dioxide away. Okay, so the cycle starts all over again. Inspiration, oxygen in; expiration, CO2 and other gas waste materials out. What I need you guys to start getting familiar with are these terms or these acronyms that we use. So when we're talking about oxygen, okay, PaO2 stands for pulmonary artery oxygen. Okay. Again, these are acronyms and units that we use to determine the amount of oxygen supply within arterial blood. The next one here is PaCO2, which is again a pulmonary artery carbon dioxide. We do different types of tests to determine the amount of oxygen and carbon dioxide within the circulatory system. If you have too much carbon dioxide, this is known as hypercapnia or hypercarbia, which I'll talk about a little in more extent later on. But if you have too much of this, if you have too much carbon dioxide in your body, it can cause irregular breathing because you get short of breath. Essentially what this is, if you have too much carbon dioxide, that means you don't have enough oxygen. And what we've talked about in the past is if you don't have enough oxygen in your body, it triggers the mechanism where you start to breathe a little bit faster. You guys remember that? Okay. Your body is again deprived of oxygen, so you start to breathe a little bit faster. Your heart rate goes up. Remember all that? So when you don't have enough oxygen in your body, hypercapnia happens, so you become short of breath. Okay? You may have some irregular heartbeats, and because there isn't any oxygen going to your vital tissues and organs, and especially your brain, it can cause changes in your level of consciousness. Okay? Then we have here bicarbonate. The acronym is HCO3. Okay? Bicarbonate in your body controls the pH balance. It maintains the balance between acidity and alkalinity. Your body blood pH is usually around in the upper sixes, like 6.7, 6.8, around 7 being neutral. Okay? We'll talk about pH balance here again in just a little bit. Now, if your body's pH is not balanced, your body cannot effectively assimilate the different vitamins and minerals of your body. Okay? So it affects the metabolism. So let's talk about pulmonary function. Pulmonary function, especially when we're talking about perfusion. You guys remember perfusion? Perfusion is the exchange of oxygen and carbon dioxide. Perfusion is your body's ability to utilize oxygen. Okay, that's perfusion. So what we're going to do here is, again, remember those set of acronyms, or your chemical acronyms here, chemistry. We do what's known as an ABG. Okay, ABG stands for arterial blood gases. Arterial blood gases. So we will take a sample. We will take a sample of your arterial blood and do different measurements of these different things. Okay, we can measure the amount of oxygen in your arterial blood. Remember, pulmonary artery oxygen. Okay, measured in millimeters per mercury. We can also measure the amount of carbon dioxide, as well as the acidity or alkalinity of your blood. 7 being neutral. Anything less than 7 is considered acidic. Anything greater than 7 is considered alkaline. Okay? In excessive amounts, whether acidic or alkaline, it's bad, and your body cannot handle those types of situations. Saturation. Saturation refers to the percentage of hemoglobin containing oxygen. Remember, hemoglobin is the part of the blood cells that carries oxygen as well as gas waste, like carbon dioxide. The difference between this and oxygen in blood, this is pulmonary artery O2, so this is measuring the amount in units. Whereas in saturation, it measures it in percentages. Okay? You have PaO2 for the amount, then you have SA, which stands for saturation oxygen, and it's written out as a percentage. Now we can simply measure the amount of saturation, the saturation of oxygen in your blood. Have you guys ever been to the hospital and they put that finger probe here? Have you guys ever been? Mm-hmm. So not only takes your pulse, but there are also probes that measures the amount of oxygen within your hemoglobin. And then the readout comes out in a percentage, and anything that's 97% or higher is good. 97% or higher of oxygen in your blood is good. Now, I want you to just think about this for just a moment, and we'll discuss this in just a little bit. But when we do a saturation of your blood, again, the percentage of hemoglobin carrying oxygen, it will bounce from 100 and down. It fluctuates from 97 to 100. Rarely does it stay continuous at 100%. Okay, why? Just think about that for a moment, okay? Here's an example of a pH scale, just to give you an idea of the difference between acidity and alkalinity. Here we are at 7, this is neutral. Blood usually is around this area. Anything less than 7, okay? You've got, what is this? Fish reproduction, no wait, adult fish, vinegar. Starts to get in vinegar, then you got lemon juice, and you got battery acid, being the strongest in acidity. And then you got the opposite here. Anything greater than 7, you've got baking soda, seawater, milk of magnesia, ammonia, and then lye. All right. So again, your pH balance normally for us is between 7.35 and 7.45. Blood is usually around the high 6s. Okay, so keep that in mind. Your pulmonary carbon dioxide is usually between 32 to 45 millimeters per mercury. Your PaO2 is between 80 to 100 millimeters of mercury. And then your bicarbonate, HCO3, 20 to 26. And then your saturation, again, anything 97% and above is good. All right, let's talk about some oxygen terms. First one here is hypoxemia. Hypo meaning what?
Below.
Below, okay, so we're talking about oxygen levels that are very low. So by definition, is generally defined as decreased partial pressure of oxygen in blood, sometimes specifically as less than 60 millimeters of Hg, or causing hemoglobin oxygen saturation of below 90%. Remember, 97% and above is better, okay? When it starts to approach the 90s, it's gonna be a red flag. And especially if it's below 90, now that becomes an emergency, okay? Now it becomes an emergency. All right, hypercapnia, also known as hypercarbia, is a condition where you have more carbon dioxide than you do oxygen. As we said earlier, when you have too much carbon dioxide in your body, it makes it difficult to assimilate or metabolize the different nutrients, vitamins, minerals, okay? Anything of that nature, it makes it difficult for your body to assimilate that, okay? Breathing becomes irregular, can change levels of consciousness, okay? Now, oxygen, is it considered a drug? Why? I mean, it's all over the place, right? Do we get high on oxygen? Yeah, because it can cause physiologic changes, okay? If you have too much of it, okay, when it's mild, it is reversible, and it can cause some inflammation of the trachea and bronchus, but it is reversible. Now, if you have too much of it, now it can cause damage to your lung tissue, and may not be reversible, okay, so you can cause permanent damage. The breathing apparatus, which we'll be talking about in the next slide, the breathing apparatus is clean, but it's not sterile, okay? It's clean, but we still want to keep one tubing, one breathing apparatus for that patient. We don't go around using the same tubing for other patients, okay? So it must be kept clean. Oxygen is combustible, right? To have a fire, you need oxygen, okay? So it is combustible. The receptacle, the tank or the canister, which holds the oxygen, is very high in pressure, okay? It says here that the tank itself is approximately 2,000 pounds of pressure per square inch. 2,000 pounds of pressure per square inch. Have you guys ever heard this term before, per square inch? PSI? PSI, okay? I'm gonna give you guys an analogy here. We're talking about 2,000 pounds of pressure within that canister. Your tire, when fully inflated, is between 28 to 34. 28 to 34 PSI. Have you guys ever seen a tire explode? Okay. YouTube it. Okay. It is crazy, especially if you're around a tire when it explodes. It can cause pretty bad damage. That's 28 to 34. What are we talking about here?
2,000.
2,000. All right. So the proper way to store an oxygen tank is not like this, standing on end. Because if you knock that thing over, that mechanical shock can cause the top, the valve, to break off. The tank itself or the valves themselves can act as a dangerous projectile. Okay? So you never leave it standing up like that. It has to be in some sort of holder. So if you're going to put it in an upright position, put it in some type of holder, a holding device. Okay? Or lay it down so it doesn't accidentally get knocked over. Okay? On the top of the tanks, you got two regulators. Okay? Two regulators. One to tell us how much oxygen is in the tank. And this is something that we should do on a daily basis when you're doing your room check. So you're checking your CPR card, your defibrillator, one thing you should also be checking is your oxygen supply to make sure that it is full. Okay, that is your responsibility, because let's say an emergency arises in your procedural room. Okay, patient needs oxygen. You're taking out the tank. Oh, it's empty. Okay, so it's your responsibility to make sure that you have a full tank at the beginning of the day. Your other valve is going to determine the rate of flow. The rate of flow is written as liters per minute, LPM. Okay, liters per minute. So again, two valves, one to determine the amount of oxygen in the tank, and the other one to regulate oxygen flow. Sorry, guys. All right. Let's talk about the different types of oxygen delivery systems. This is probably going to be the most common that you've seen. It's a nasal cannula, plastic tubing with two prongs at the end, which goes inside the nostril. Okay? Then you have a strap that goes around your face and over the ears to keep it secure. All right? Now, the nasal cannula is for long term. It is very comfortable and convenient. It only gets uncomfortable when there's so much air going into the nose, it dries up the mucus lining. Okay? So your nose may become irritated, and it may also cause your nose to bleed. Okay? But we usually do it in low flows, around 2 to 4 liters per minute. 2 to 4 liters per minute, okay, on the average. You can go as low as 1, but it doesn't do anything. So we go a little bit about 2 to 4 liters per minute on average. For children, it's a little bit less. Now, the delivery of the oxygen, when placed around the nostril, like so, inside the nostril, the concentration of oxygen is only between 21 to 60%. 21 to 60%. Well, isn't oxygen pure coming out of the tank? Yes, oxygen coming out of the tank is 100% pure oxygen. All right? But the atmospheric air that you're breathing is not 100% oxygen. So when the oxygen from the tank and atmospheric air mixes, the air that the patient is breathing becomes mixed or diluted. Are you guys with me so far? Atmospheric air is only between 20 to 25% pure oxygen. So the air that we're breathing right now is not pure. It's between 20 to 25% oxygen. Okay?
So does the percentage goes higher when the patient breathing that tube?
It becomes more effective, yes. The percentage does go up. Okay? We give this to patients, let's just say, remember the saturation that we take, or the ABG, the arterial blood gases. So there's the lab, and there's also the finger probe to determine their oxygen saturation. If they are teetering or below 97%, that means they're not perfusing properly. Okay? Remember, perfusion is adequate intake of oxygen, okay, to provide oxygen to your vital tissues and organs. If it's below 97%, your body is being deprived of oxygen. So they may be breathing, but the perfusion isn't effective. So we're going to help them out a little bit by giving them pure oxygen. But even still, when you have those two prongs going up the nose, the nostril isn't tightly going around the cannula, so there's still atmospheric air that's mixing with it. So even with 21 to 60%, it's still helping them out. Okay? They're still breathing, but we're just going to give them a little boost. Okay? okay, to get it back over that 97% or better in their saturation. Does that make sense? Okay. Next one here is the nasal catheter. Nasal catheter, not so common, but this is also on low flow between 2 to 4, 1 to 4. But it says here higher O2 concentration. Why? Because the tip of the catheter is not on the outside now, it's in the inside within the nasal cavity or the nasal pharynx. Okay? So it's a little bit more pure. It doesn't mix with atmospheric air as much. Okay, so the concentration will maintain or be a little bit better. Now, it says here that it may cause stomach distension and dry the mucous membranes. Well, why do you think it would cause? Why do you think it would cause the stomach to distend?
Let's go down the esophagus.
Exactly. Look at where the tip of the catheter is. It's up here. Down here in the neck area, you've got two pipes. You got the windpipe and you've got the food pipe, right? Your esophagus and your trachea. So as air is being pumped in, yes, some of the air will go down the trachea, but some of the air will also go down the esophagus, causing the stomach to distend. And that's another reason why, although the concentration may be high, the delivery of oxygen to better perfuse the body may only be a little bit better, but not as great. Okay? Let's go to the next one. The face mask. The face mask covers the nose and the mouth. But just like the other devices, it doesn't seal tightly around the area. Okay? So there still can be a mix of atmospheric air. But it's a lot better. It is a lot better. Okay? This is for short term, but you have a mask on. Very difficult to talk. Very difficult to eat and drink. Can't put a thermometer in your mouth, right? So it makes it a little bit more complicated, but it makes the oxygen more pure than the other devices. So it doesn't fit tightly around the nose and mouth, so you still have about 30 to 50% concentration. It doesn't operate less than 5 liters per minute. Okay? Anybody who has this mask, and I'm going to say 90+% of the time, they've got the oxygen going 15 liters per minute plus. I've never seen it lower than that. Okay, usually 15 liters per minute plus. You got two different types of masks. First one here is a non-breather. The air is constant, the oxygen is constant, and there is a valve to prevent any carbon dioxide from mixing with the oxygen. So the air coming in is more pure. Okay? That's called a non-rebreather mask, a non-rebreather mask. Then you have a partial rebreather. It also has a valve of some sort. Okay, it says no valve, but it's still a valve. Okay? It's not a valve that completely shuts off the carbon dioxide because it's partial, and your concentration is going to be between 60 and 90%. So how do we determine what mechanism or device to use? Well, it's all based on their saturation levels. Okay? Again, we're talking about patients who are breathing. We're just going to help them out a little bit. So do they need a little help, or do they need a lot of help in increasing their perfusion? Okay? And remember, if you give too much, it can be lethal, right? So it can cause lung tissue damage. So we want to help them out, but we also want to make sure we're not going to cause any damage to their lungs. All right? Because it is a drug or medication, you as technologists or any clinician cannot just put a mask or a cannula on your patient without the direction of a physician saying, yeah, they need to have oxygen. You can't just take it upon yourself. Okay, they'll let you know, yeah, put a cannula on, put a mask on. Let's put them at 4 liters per minute. Let's put it at 15 liters per minute. They'll tell you what to do. You can't take it upon yourself. Okay? Any questions? All right. Then we have mechanical ventilation. A mechanical ventilator, and we're going to spend a little bit more time on this later on, but a mechanical ventilator, this is also known as a respirator. This is when the patient cannot breathe on their own. They cannot breathe on their own for some reason or another. Okay? So what we'll do is we will put an artificial tube down their throat. There's two ways to hook them up. One would be through a tracheostomy. Okay, so we're going to create an artificial opening through their neck and into the trachea. So there's an artificial opening, and we're going to put a tube through there. Okay, so one tube is in their throat. The other end of the tube is going to hook up to the machine, and the machine is going to breathe for them. That's a tracheostomy. The other one is known as an endo. Endo meaning what? Within or inside. An endotracheal tube. Have you ever heard of ET tubes? Mm-hmm. Endotracheal tube. So instead of creating a hole here, there's going to be a tube that goes down their throat, down their trachea, and then at the other end, we'll hook them up to the machine as well. These are for patients who cannot breathe on their own. Okay? So we'll talk about this a little bit towards the end of the presentation. Yes?
I was going to say, would you use an endotracheal tube when the person has their throat swelling shut to prevent it from collapsing?
Okay, so the question is, are we going to do an ET tube if the throat has swollen shut? No, then you would poke a hole. You do an os, a tracheostomy.
Okay.
Okay? Okay. Urinary catheters. Urinary catheters. Okay, so here it says radiographers often deal with patients having urinary catheters. So they have a catheter coming out of their urethra with a bag or receptacle, a collecting receptacle, hanging at the side of their bed or on the side of their wheelchair or strapped around their legs. Okay, very common, very common. So these catheters, they're made of plastic, silicone, or rubber, and they're inserted through the urethra and into the bladder. Why would somebody have a urinary catheter? Number one, it keeps the bladder empty while the surrounding tissue heals after surgery. So there's constant drainage, and the urine doesn't stay in the bladder for a long period of time. It helps the bladder to heal. Number two, it is used to drain, irrigate, or instill medication into the bladder. Okay, so we're either going to remove something or put something in there and into the bladder by way of the tube. Okay, number three, it will assist the incontinent. What does incontinent mean?
Can't pee.
Okay, incontinent, or they lack the either incontinent or they lack the control to hold their pee or go pee. Okay, incontinent. Number four, this refers back to number one here, bladder retraining. So they've had bladder surgery. They'll have a catheter inserted in there, so it allows the urine to drain freely out of the bladder while they regain control and muscle in the bladder right after surgery. And then number five, the tubing or the catheter allows us access to take samples of the tissue, so we can sample a specimen. We can determine if there's a malformation or injury in that bladder by way of using this tube. Okay, yes?
For ultrasound, I know that when taking images of the bladder, it has to be full. So how would that work for ultrasound technicians?
Well, what do you mean by that?
Like when taking images, I know
Mhm.
it makes it better when a bladder is full to see what's going on.
Right,
in
so
it.
okay, so going back to what you, okay, so it goes back to number five here.
Okay.
Okay, determining malformation.
Okay.
Okay, we'll put a catheter in there to maybe fill up the bladder.
Oh,
If
I
they're
see.
unable to fill it up themselves, we will fill it up. Radiographically, what we'll do is, for radiographers, the catheter will go in there and we will inject contrast through that catheter, so now we see a lining of the bladder. right here. It's called a cystogram. Okay? So we also use different catheters for imaging purposes. Okay? So in addition to what we've had listed here, we also have these urinary catheters to do different types of radiographic studies. The first one here is a cystogram or cystography. We'll place one of these rubber silicone catheters into the urethra and into the bladder, and then at the one end here, we will connect it to a syringe or maybe a bottle, and we will bolus the contrast into the bladder, and then we start taking pictures in different positions. Okay? We also have what's known as a VCUG. A VCUG, which stands for voiding cystourethrogram. Voiding cystourethrogram. What does cyst mean?
The
Is that-
filled sac.
Yeah, it just means bladder. Okay, a bladder is a very basic term. A bladder could be anything. Okay, that is a sac. Okay, so voiding cystourethrogram. Okay, it's going to be a radiographic study of the bladder and the urethra. What do you mean the urethra? Well, after we put contrast into the bladder, we'll have the patient pee. Okay, so they'll be peeing the contrast, which is mixed with the urine, and we get to see the urethra. Okay, usually done with children. Usually done with children. Okay, so we'll just pull the catheter out, and all of a sudden they just start peeing on their own, and we start taking a picture of the bladder as it empties, as well as the urethral tubing. Okay, that's a VCUG. All right, then we have a ureteral stent